Okay, and we're live now.
Welcome
Good morning,
everyone.
everyone.
Welcome.
Go on.
Oh, sorry. Welcome everyone. Welcome back to another session with Predental Universe. I'm Tiffany, one of the predental students monitoring today's session. We have an exciting presentation today with Dr. Rai. And on that note, feel free to take it whenever you're ready, Dr. Rai.
Hi, good morning, all. So, my name is Kunal Rai. I'm a dentist based in Leeds in the UK. I want to keep it as interactive and as informal as possible. So, the topic today I'm going to talk about is smile transformation using the ABC concept. So, if you don't know anything about the ABC and you know anything and you want to just jot it down, fingers across, let's see what you think about it. I'll give you a few minutes for that. Just move on to the next slide. So a mugshot of myself. I'm quickly just going to introduce myself. As you already know, my name's Dr. Kunal Rai. I graduated in the year 2015 from Charles University in Prague. I'm a finalist young dentist in the year 2020 and 2021. Just haven't managed to pass that final hurdle, hopefully next year. I do work in clinics 4 days a week as an aesthetic and implant dentist. I am a clinical teaching fellow at the Leeds Dental School, which is in the top 5 in the UK, primarily looking after the 5th years, final year students, and a few 4th year students. As every dentist, we want to share cases, and I do that too on Instagram. My handle is Kunal Rai _dentistry. I haven't just done a basic dental degree. I am also doing some further qualification. I first of all, once after I qualified, I did a PG certificate in restorative dentistry, just because I wanted to hone my skills in the conservative dentistry, doing veneers, crown, prosthetic work, because I didn't get as much experience as I wanted whilst at university. I've also done a master's in dental implantology. I've just actually finished it, and next week I get my results. Hopefully, good luck to myself. Hopefully, it's gone well. I've also enrolled to a PG diploma, clear line therapy. You may know it as Invisalign. It's just to, again, hone my skills with it and to get a better understanding. It's always good to get further qualification. With a caveat to that is you get some wide beards with it, but hey. So let's begin. What is the ABC concept? We live in a world where minimal invasive dentistry has kicked in. We want to save as much as teeth as possible. So in line with that, the ABC concept comes in well. A stands for aligning the teeth, getting the right, correct alignment of your teeth. B, brightening up the teeth. And C is contouring. Contouring could be basic things such as composite edge bonding, a simple filling, composite veneers, prosthetic work such as crowns, porcelain veneers, bridges, implants. So I had a patient, Ollie, who came to see me. Whenever a patient comes in, we just don't crack on with the treatment. I like to sit down with the patient, build a rapport with them, try to understand what they want, and make them feel at ease. I always have the same question to any new patient. If you were given a magic wand, what would you like to see with your teeth? Ollie's answer was, I want straighter, whiter, and a shape improvement. In his own words, his main concern was when I was younger, I wasn't bothered. Now I am in front of people. I'm conscious of my teeth. I would like them to be straighter, whiter, and shape improvement. Again, I don't just crack on. I like to build rapport, and I like to make them feel at ease. I like to go into further information. I asked them about the medical history, social history, dental history, and family history. Medical history-wise, Ollie was fit and well. However, he had an allergy to penicillin. Why do we need to know about these allergies? Just in case he ever has an infection, we know what medication not to give him. The purpose of the antibiotic is to make him feel better. But if we give an antibiotic that he's allergic to, it's just going to make matter worse. Moving on to social history. We need to know about the alcohol content, if he's a smoker, what job he does, and the stress level. Why alcohol? In the UK, first of all, in the UK, they say that less than 14 units a week is an acceptable figure. So that essentially is about 7 pints a week. With alcohol, basically, if you have any composite work done, it becomes porous and it makes it more likely to fail, discolor. With smoking, we also need to know if a patient is a smoker, because smoking can stain your teeth, which means that whitening, if a patient is doing whitening, it may take longer. If a patient is a smoker, they may have to do the whitening top up quite often. General norm is about every once a year, but for a smoker, it may be every 6 months. Why do we need to know about the patient's occupation? The occupation helps us understand how stressful the person is. Because if a person is stressful, they're most likely, or highly likely, shall I say, are going to fracture some of their work. So we need to understand that. We need to make them aware from the onset that these are the risks. It also helps us in the writing of the treatment plan. Dental history. Why do we need to know about the dental history? Patients, it shows us how motivated the patient is, how well they are looking after their teeth. In Ollie's case, he brushed with an electric toothbrush, which is brilliant, and he used a fluoridated toothpaste. However, he only did that once a day, which is not good enough. We need to ensure that he brushes twice a day. Brushing itself is not enough. We need to make use of some additional appliances. But brushing itself, in my eye, only cleans about 60% of your teeth. If you imagine this as your teeth, the brush will only clean 1, 2, 3 surfaces. You cannot move your teeth physically and brush inside, so you need the interdental appliances. Mouthwash, for me, I'm not a big advocate of mouthwash. For me, a mouthwash is like coming out of the shower and spraying yourself with some aftershave body spray. As long as you brush and you use some interdental appliances, that's sufficient. Why do we need to know about the last dental visit? In Ollie's case, it was over 2 years. It shows if the patient is motivated. In his case, though he was motivated, hence why he came to see us, he had a bad experience in the past. He only saw a dentist over 2 years ago. So we need to make him settle. We need to make him feel at ease. We need to understand him so he feels relaxed. Family history. In his case, there was no history of hereditary condition. Why? Because gum disease, which the technical term is periodontitis, these are generally autodominant disorders, so it can run in generations. So if that is the case, we need to make sure that he has nice, healthy gums before we do any elective work. So we sat down with Ollie on the dental chair, as always. We did an examination. Now, examination is just not looking at inside the mouth. It's about how does everything fit together. We look externally, the neck, the joints, the open and close movement. Is there a click? Is there a deviation? Then we look inside the mouth. We look at the teeth, the tongue, and everything pink inside the mouth. We need to ensure everything is nice and healthy. Oral hygiene, in his case, I'm not surprised. He had calculus built up. Calculus is also known as tartar. Plaque. Plaque is just a fancy term, a posher word of saying bacteria is in your mouth. It's basically a biofilm of bacteria. Because he only brushed once a day, it was highly built up. So first of all, we need to ensure that he had an improvement in his oral hygiene. I'm not going to bore you guys with his dentition, but I'm just going to tell you about some key findings. He had multiple restoration, which comprise of silver fillings. Silver fillings are basically amalgam. And he had some missing teeth. In the UK, we use notations such as upper right 6, lower left 7. All around the world, different notation. You may know it by numbers. It could be 16, it could be 37. Periodontal exam. This is basically to see the status of the gums, how healthy they are. Luckily, even though he hadn't been to a dentist for 2 years and didn't brush twice a day, he still had an average gum status. He didn't have any pockets greater than 3 millimeters. There was no history of attachment loss, recession. And the basic periodontal examination was just a mild inflammation. It's also BPE is also known as CPI. The thickness of the gum, which we term as biotype, was normal. Because he came with an orthodontic mindset, we did some orthodontic review. We looked at the skeletal base. Is there was a class 1, class 2, or a class 3? How do we define it? Basically, you can take a picture and you can draw a line from the forehead all the way down. Does the chin and the forehead come in one line? If it is one line, that's a class 1. If it's behind, it's a class 2. In my case, it's a class 2. But in all these cases, it was a class 1. The overjet. Overjet is to do with the horizontal relationship of the teeth between the upper and the lower arch. An ideal figure is somewhere between 2 to 4 millimeter. Overbite is the vertical relationship between your upper and your lower teeth. It should be somewhere around 30% is our ideal. In his case, it was 20. Now, the incisal relationship, this is to do with the top and the bottom teeth. Does it touch just at the tip, or middle, or right at the top? In his case, it was a class 3 at the tip. An ideal one is a class 1. As a new patient, we did some special tests. We did a cold test. It's really cold. We do it using cotton pallet. And we found that one of the tooth was not vital. It was a dead tooth, which he was unaware of. For every patient, we do an X-ray. There are various types of X-rays. You can, the X-ray called OPT, there's a CBCT, there's a bite-wing, periapical. Every X-ray has a merit something. In this case, I did an OPT. Why was this my choice of X-ray? Because we wanted to see the full teeth in one arch, and we wanted to see if there's any. We were doing some also work here. We wanted to see if there's anything cynical, like maybe a tooth growing under the gum that we cannot see with the naked eye. If that is the case, it will not help in the movements of the other teeth. And this is just a radiographic finding, which you always need to do. From the X-ray and the examination, we generated a problem list, and I always divide it into 4 categories: aesthetics, bite relationship, which is the technical term is occlusion, the dentition, and the biological, the pink tissue in the mouth. So from the aesthetic, we gathered that the teeth, I will show you pictures of his teeth just after this, so you get an idea. The teeth shade in his case is C3. Now, worldwide, we have a uniform shading shade map, which is the bitter shade map. And in that ray, he had a C3. Alongside, he had a chipped upper central left tooth, which is this one. Yeah, it was chipped. He had some black marks present on his teeth. He had a deficient buccal corridor. What does a buccal corridor mean? So when you smile, and if you look in the mirror, if you don't show your back teeth, that's a deficient buccal corridor. If your teeth are flared out, that's a nice buccal corridor. And the upper left central teeth was tilted. It wasn't straight. It was tilted one way. From the bite relationship, he had some crowding. The Hollywood smile is generally a U-shaped arch. In his case, it was a V shape. Then the canine relationship generally should be a class 1, and ideal one is always a class 1. But in my eye, as long as you've got a healthy occlusion, it is fine. Incisal relationship, as mentioned, was a class 3, and he had a reduced overbite. Dentition. Now, if we go back to the X-ray, we can see some clouding here. This clouding is an indication of an infection. But as I mentioned at the start, this was not his main concern. He was not even aware of this as an infection. So we call it a chronic. It's not an acute pain. It's at the end of the tooth. So it's apical, and it's in the gummy tissue. So we call it periodontitis. Hence why it's called chronic apical periodontitis. There are some tooth wear, some grinding on the upper, from the canine to the canine. And from the pink tissue, he had some mild bleeding. A healthy tissue should be pink in color with some stripping, like an orange skin cut. But in his case, it was just red. From the problem list, we derived a treatment decision, whether we want to accept, improve, or correct something. So from the aesthetic aspect, we wanted to improve the buccal corridor. We wanted to give him a nicer smile. We definitely wanted to improve the teeth shade, do something about the chip tooth, about the black marks and the tilting. From a bite relationship, we wanted to correct the overbite, the crowding, the arch shape, the canine relationship, and the incisor relationship. We definitely want to do something about the infection. Otherwise, it will spread, and eventually he will lose that tooth. Tooth wear we want to improve, as well as the biological envelope. So to show you some pre-treatment photograph, this was done using my Canon camera. The black stains I was talking to you about, you can see it there, you can see it there. The chip tooth is clearly visible here, a quite dark too. Just to make you aware, at this point, we had to force him to smile. Ollie did not like to smile in front of the camera. He was quite, he didn't feel confident smiling in front of the camera. So it's more of a forced smile here. And you can see the crowding on the lower teeth. This was a scan done using the Invisalign scanner. The red things I will talk to you about later, but this just shows what his teeth look like. So connecting the jigsaw together, we derived a treatment plan for him. I always divide it into 4 categories: emergency, stabilization, restorative, and maintenance. Emergency, if a patient is in pain, we want to get the patient out of pain straight away. But thank God he was in no pain, so that was not required. The next step was to get that biology, the foundation, strong. So we did a scan, we referred him to the dental therapist for some oral hygiene instructions, tooth brushing instruction, and a good clean of his teeth. The next stage was to get rid of that infection, because we don't want to do anything elective until the foundation is strong. So he was referred to the endodontist for the treatment of the lower right side, so the lower first premolar on the right side. Once everything was done from the endodontist, the dental therapist, then he was referred back to myself, and this is where we cracked on with the ABC concept. So now, what is the ABC concept? So A is basically for alignment, which you use in Invisalign Go Plus, B for bleaching, C for contouring. And then once all of this was done, we did a maintenance phase where Ollie was given a set of retainers to wear lifelong. Now, coming back to now the treatment. So the advantage of doing a PG diploma is I know now how Invisalign works. I just don't rely on the technician telling me, based on computer simulation, this is what can be achieved. I tell them what I want. So I do a 4-step treatment prescription. The first one I write is the patient's chief complaint, what he did not like. So in his case, patient doesn't like his smile at all. Please improve the upper and lower crowding and widen the smile. Level the gingival margin of the upper anterior teeth. No movement on the lower right side. That is the tooth where the infection was, until a certain number aligner, such as 12. Now for the upper teeth, I asked him to tip the upper right one buccally and then align everything together. Posterior, I want to widen the smile, so I've asked him to use one of the best tooth, the top 7. So the penultimate tooth in the arch to widen the smile, and I defined how much horizontal and vertical relationship I would like at the end of the treatment. So this was its initial position. You can see that the gingiva is quite low this side compared to that. So we got it into a nice level. So the central, the canine, should almost be in line, and the lateral is generally from a smile perspective should be 0.5 millimeter below them. So that's what I've asked them to do. So they are all in line now. The crossover there has been resolved. There was a crossover there that's been resolved. I'll show you from a different angle. So this is his initial bite. This is his upper arch at the end of treatment. I've told Invisalign to use this cusp to align, to widen the posterior teeth. This is the lower arch. You can see the crossover there that has been resolved. So it's a nice U. So come from a V, we move into a U. All in all, it took about 15 aligners on the top arch, 15 aligners on the lower. So in total, it took about 15 weeks. Now, going back, these red things, these are called attachments. What are attachments? Attachment basically helps to make the treatment more predictable, helps in certain movements. For any kind of, not just Invisalign, any kind of braces to work, there are three factors. You need space, you need time, and you need force. Three variables, they are very important. So I will test you on these. I will ask you again at the end. So space can be created either by taking a tooth out, by surgery, or by shaving some teeth. Time, with Invisalign, you need to wear them at least 20 hours a day. And force comes by the retainers itself. With Invisalign, the beauty of Invisalign is that they smother the teeth in almost 360 coverage. So you're getting that force, constant force all around, which helps in the movements. There was no additional aligners required, so the treatment was basically completed in 4 months. The patient, as expected, more than 20 plus hours a day, and he changed them every 7 days. Based on my patients, all my patients' experience, I've done more than 100 cases with Invisalign. They always said that changing at night time helps them as they are sleeping with the pain. Now, with everything, there are alternative treatment. There are some kind of destructive treatments, such as crowns. You can have different types of braces, such as lingual orthodontic, conventional orthodontics, veneers. One thing you need to keep in mind is that what you need to keep in mind is that with fixed braces, there are certain wires that only do one movement at a time. Hence why it takes such a long time. Whereas in Invisalign, they can do multiple movements at the same time, which makes the treatment shorter. So once then we moved on to B, bleaching. This was done in sync with the alignments from day one. Every country has their own bleaching products. In UK, there are Enlighten, there are Polar, and we got boutique whitening. I find boutique whitening works good for me, and this is what I prescribe to my patients. I asked Ollie to start using it from day one. I showed him how to use it. It's important that a pea-sized amount is applied to the trays. Total number of syringes used in his case, they come in about 2 ml syringes. He used about 4 syringes. Is to lift the shade of the teeth, and they basically, how they work is they diffuse. A tooth is basically made of 3 layers. Enamel, the outermost shell, middle layer is called the dentin, and then you got the pulp, which is the live tissue, where the blood supply comes, the nerves come. So what happens is when you put a bleaching product, which is generally hydrogen peroxide or carbonate peroxide, they diffuse from the outer shell, which is the enamel, as I mentioned, into the dentin, which is generally yellow in color in adults. So that is where it goes into diffuses and lightens that color. So this is at the end of the A and B concept. So the teeth are now aligned. They look much more white in color. Then we moved on to the final stage of the ABC concept, contouring. Here we used composite, and aesthetic work was achieved. Additive bonding applied to the upper anteriors. For any of my work, I like to use a rubber dam. The purpose of a rubber dam is it helps me to focus on the teeth I need to work with. It helps to keep blood away. It gives me a nice moisture control. The composite, again, everyone has different preference. My preference is Ivoclar's Emperors. Once you become a dentist and start working, you just have to get your hand settled to which one you like. Composite, after composite, you need to polish them. The polishing is the process that takes the most of the time to get that high luster. So that's what rubber dam looks. The white things, these are called floss ties. You basically tie them to keep the rubber tucked into the gums. And what you can see, the silver thing, these are called the clamps, they help to keep in position. And at the end, this is what his teeth look like after the A, B, and C. So there's no black marks anymore. There's no fractures anymore. All the teeth lengths are improved. They've got more of a C shape to it. Then we moved on to retention. Retention protocol, basically we gave him a set of Beverages retainer. Once you have your teeth moved in position, it needs to be held in that position. Unfortunately, after we pass the age 16, our bone is used to that position of the teeth. So it's like a spring. They always want to go back to it. So we need to counteract that. So we need to wear retainers. Patients always ask me, how long do we need to wear the retainers? I always ask a question back to them. How long would they like to have their teeth straight? Depending on the answer, that is how long you want to wear the retainers. So this was a before picture. At this stage, I just want to, this was again a forced smile. He did not like to smile, and you can see he's got nice straight teeth. And he's also got a tan. The tan was not done by me. He just been a hot month over in England, and so he's got a nice tan. A video showing the smile. He was quite happy as Larry, and the good thing is, I can say that he was a very incompetent person. Now he's quite confident, and to add to it, he's now even got a girlfriend, which I can take credit for, because he's got nice teeth now. After every treatment, I like to reflect on it. In this case, the main thing was we met his requirements. All his chief concerns were answered. We have now built a rapport with him. He feels comfortable coming to us. So the patient management was excellent. Team working, we made use of an endodontist. We made use of the nurses, of a technician who basically did the scan, the endodontist. Everything was done in the right manner. Right, open the stage for questions, if there are any.
Thank you so much, Dr. Rai, for taking the time to prepare this presentation. It was very informative, and we enjoyed learning about your cases and experiences. With that said, we do have a few questions in the chat. So yes. The first question is, how do you, when a treatment doesn't go according to plan, how do you proceed in terms of interacting with the patient?
It's just a matter of being honest with the patient. You should never hide. Don't go with the mindset that everything will work. Sometimes you are going to get the setback. And if you get a setback, you should always put your hands up and admit it. Patients are always, they always like for the dentist to be honest, and that helps with the relationship. If you hide behind and don't be honest, that's when you get complaints. So if something went wrong, I would put my hands up, say, this hasn't gone to plan. I would like to take a step back and see how we can improve onto it.
Thank you so much, Dr. Rai, for your answer and for your presentation. Our next question is, how many hours do you recommend patients to wear their retainers after treatment per day?
So for me, there are two types of relapse: a rapid relapse and a slow relapse. The rapid relapse occurs in the first 6 months. So if you think of these as a teeth, it's just not teeth surrounded by pink tissue. Under the pink tissue, shall I say, you've got bone, you've got ligaments. The ligament is like a spring. Once you move a tooth, it always wants to go mold back into an original position. So if you don't wear your retainer in the first 6 months, it will straight away pull it back. So to fight that, you need to wear your retainers for at least 20 hours. After that, you can wear it at least 5 out of 7 days if you want to retain that position. Always keep in mind though, teeth are attached to bones. As age goes by, your bone is changing shape. So it will never be 100% to the position that at the end of your alignment it It will always change, but by wearing the retainer, you are keeping it low. You are basically restricting that fast movement.
Thank you, Dr. Rai. So the next question we have is, what is one piece of advice that you wish you would give a future dentist that you wish someone had given you?
Sorry, repeat the question again.
So the next question is, what is one piece of advice that you wish someone had given you that you would give to a future dentist?
What I would say is that don't try and explore don't be a jack of all trades, master of none. Pick an area of dentistry that you like and just try and do extra work in there, shadow people. Having a mentor in your life is very important. Even though I've been qualified for 6 years, I always fall back to my mentor and I always ask him questions. You will always learn.
Thank you so much, Dr. Rai. Our next question is, can one feel or sense if they have calculus buildup?
Yeah. So in your mouth, if you look, you've got an upper arch and you've got a lower arch. How does calculus get built up? Calculus is basically the deposit of calcium. Now, calcium comes out from your salivary glands. You've got a salivary gland here, 2 salivary ducts down here, and 1 salivary duct down here. So if you'll notice, behind your lower anteriors, i.e. these teeth, you may get a lot of deposits. That's because if you lift your tongue around that area, you've got the calcium deposit coming out. So when you rub, you might find a thick layer. And another spot to work out is your top back molars. Around there, you'll find a lot of calculus built around. That is mainly due to, it could be due to not flossing, not using anti-dental appliances, because they stick into the small places in between your teeth.
Thank you, Dr. Rai. So the next question is, what led you to be interested specifically in this specific specialty, like in regard to implants, instead of just being a general dentist?
First, when I qualified, I never had that interest of just doing, for me, just looking at seeing patients, telling them they need a filling, they need to brush their teeth. I was never interested in that. I wanted to do something that involved, for some odd reason, I just like blood. So for me, dental implantology was something similar to doing surgery, but on a lower scale. So and you get the pleasure, like you're helping someone to improve their quality of the life. You can do a lot of. I still do fillings. Don't get me wrong. I still do checkup, but also about the pleasure I get after doing a surgery. I only see 2-3 patients a day for implants, and the life change that you get out of it. So just to give you a real example, I had a patient who had dentures, but she could not eat at all. Her quality of life was very affected. She didn't like going out because her dentures keep falling out. But now, after putting implants in there, the quality, she doesn't have to worry about that because it's all fixed now. The satisfaction you get at the end of that, because you've done something to help, is what made me why I wanted to do masters. And it also makes you stand out. Everyone can place implants, but if you do a master, it makes you stand out. You have a better understanding.
Thank you so much, Dr. Rai, for your response. Our next question is, when fixing chips on teeth, do you have to file before bonding?
No, yes and no. We don't have to file a lot of tooth material down. You just want to file a thin buff, like a bevel, so that you can blend the composite to it, any kind of filling to it. So it doesn't look like there's something added onto it. You can't see the added margin to it.
Great. Thank you so much, Dr. Rai.
No problem. So always remember, going back to that last question, is you are not shaving, you're not drilling, but where you are just beveling, you're making a very thin, smooth layer to it so you can blend the work.
So another question that we have is, you said that braces, they adjust with one motion.
Say that again?
And Invisalign, they fix the teeth in multiple motions. Why do people still? I'm sorry. So previously in your presentation, you stated that fixed braces can only do one movement at a time,
Yes.
but then Invisalign, it can do multiple movements
Yes,
at the same
right.
time. So why is it that some dentists prefer fixed braces still in comparison to Invisalign?
Everyone's got their own experience. I've never worked with fixed wires. I did 3-4 cases with fixed wires, but I did the 6-month smile, and the patient came with the mindset that this treatment will be finished in 6 months. But for me, 6-month smile never finished in 6 months. It always took 9-10 months, and I always find the wires to be too fiddly. It's what your hand settles with. For me, the wire was not my forte. And personally, when I had wires, I always felt that the wire kept on digging in. I had to make multiple visits to the dentist. I had ulcerations. And to the Invisalign, where we got mentors, I found out that with wires, the thickness, each wire has a different thickness, and the thickness indicates the type of movement. And at one time, you can only do one movement, whereas with Invisalign, they are computer fabricated. So they can do multiple movements, and because you got buttons at the same time, you can do like a push, rotation, a torque, various types of changes.
Thank you so much, Dr. Rai, for your response. Another question is, would you say that your dental school well prepared you to practice as a dentist if you didn't choose to specialize?
With dental school, what you need to understand is, with dental school, you get the very basic book knowledge. What you need to know to pass. Let's be honest. Once you qualify, I always say to my students, forget what you've been taught. You need to learn from personal experience. Textbook is good. You're never going to get everything given to you on a plate. You're never going to have a nice smooth tooth where you can do a crown prep. You're going to do a crown prep on a broken tooth, I can say. You're going to do a crown prep on a filling. So you need to adjust to it. So it can never be bang on what the book says. If that answered the question, did I answer something else there?
Yes, you did answer the question. Thank you.
Okay, that's fine.
Thank you, Dr. Rai. So the next question we have is, what do you find to be the most challenging aspect of your profession?
You do get some demanding patients, and how you build a rapport with them. For me, whenever I get a patient, and I ask them to rate their smile and what they want to achieve, whenever I find a patient who, on a scale of 1 to 10, say they want to have a 10 out of 10 or 11 out of 12, anything more, I try to avoid them. Reason why, that patient have come with a very, very high expectation. With a high expectation, it's hard to meet that. But if someone comes with a low expectation, you can always build on it. My working ethic is, I like to under-promise, over-deliver.
And building up on that question, how do you deal with difficult patients?
You just sit down with the patient and just have an honest conversation with them. Say that what you want and what I can deliver to you are not going to match. So rather than going into and doing something where you're going to be not happy with it, I'd rather tell you from the start, I won't be able to meet with you. I won't be able to fulfill your requirements. And I don't want you to be unhappy with me. So I'd rather not do a treatment on you now, and then later on, I would say 6 months, 2 months down the line, you coming back to me said you did everything wrong here. So it's always, you need to be open and honest.
Thank you, Dr. Rai. Next question we have is, how did you deal with failure or disappointment during dental school, and how did you pick yourself back up?
You just need to be positive. You always need to have positive vibe. Be optimistic. You need to be optimistic. You are everyone's way of learning is different. For me, just reading didn't make sense until I had the practical aspect. If you need practical aspect, go speak to your tutor. Get that extra work in. Shadow if you need to. Go and shadow someone. You just need to open up. Unless you open up, unless you tell people what your shortfalls are, no one's a mind reader. They won't be able to tell you what to do. End of the day, we're all adults now. We know what we want to do. You need to go out and grab it with both hands.
I have a question. How do you know that a cavity is developing? Is there like any indicators without like looking at an X-ray?
A cavity, yes, you can see. So from a dentist perspective, if you look inside the mouth, a cavity may be, when you reflect light on it, it may give you a shadow. That is an indication. A cavity does not always will give you, a cavity will not always give you pain. But when a cavity gives you pain, it most likely has gone quite deep into the pulp. So like I mentioned earlier, tooth is made up of 3 layers: the enamel, the middle layer, the dentin, and then the pulp. Generally, if you have some kind of sensitivity to hot, cold, and sugar, which doesn't last a lot of time, then it means that it's somewhere in between the enamel and dentin, and a filling will work there. Whereas if you're getting like a lingering pain, that means it's gone passed from the dentin into the pulp area where the nerves are, the blood supply are. So that is where it's gone quite deep, and you need to have a very invasive technique. Now, coming back to the question, without an X-ray, how you can tell, either by symptoms or by looking in the mouth using a mirror, like you can see stainings. When you run the probe, you can find a soft area where the probe just falls into. That's a cavity. Or when you put a light in the mouth, the dentist light, and look in the mirror, if there's a reflection, like a shadow, that's an indication that there are some caries there.
Thank you, Dr. Rai. And the next question is, how do you balance your work and life?
Oh, that's been very, very hard. My wife hates me. So not only the degree, the extra degrees I'm doing, but my wife's stress I get when I come home, because I finish work about 6, 7. I come home and I'm doing my dissertation, which I've just submitted, and it was like stressful. But if you want to achieve something, you have to sacrifice somewhere. But she's happy now. Touch wood. I would strongly recommend, you just need to find that balance. If you need to take some days off work, use one day as an admin day. What I plan to do now in order to have a more balanced life is cut down on the working day, and so doing 4 days of practice, do 3.5, and use the half day where between the 9 and 5 to do my paperwork, and then I've got more time at home. Because the last thing you want to do is have loads of work, seeing patients, come back home, and then start working again. You need to find that balance, and that's where I struggled initially. But now, taking a step back, making a plan how to go forward, it will help me.
Thank you so much, Dr. Rai, for your response. Another question is, why do patients experience teeth sensitivity to cold or hot beverages? Is it an indication of anything?
Good question. Now, sensitivity to hot and cold, there could be various reasons. One of the factors could be a cavity in there. One of the factors could be that the cavity was neglected, and so it progressed through the 3 layers I mentioned. So from the to the dentin, to the pulp, and if it's gone to that, it may need a root canal. Indication is through the X-ray that will confirm whether it's gone to the pulp or there's an infection to it. Another indication is how long that pain is, sensitivity is lasting. Does it linger around? Is it just for the few seconds? That will indicate whether it's a reversible condition. A reversible condition doesn't linger around, and you don't need painkillers for that. Whereas something that lingers around, you need painkillers. That's an irreversible condition. That's quite intensive. And another reason why you can get sensitivity, if you remember, I mentioned the word biological envelope, the gums. If the gums are receded due to parafunctional habits such as grinding, clenching, aggressive brushing, it may expose the other part of the tooth that is generally not exposed. Let me just retract a step. So enamel is your outermost shell, which protects you from hot and cold in a general environment. Under the pink tissue, you don't have enamel. So if the pink tissue has shrunk due to some parafunctional habits and the roots have exposed, that could be another reason for sensitivity. So it's just not to do with caries, it's also to do with exposure of the inner surface of the tooth.
And another question is, what if it's like once someone drinks something, like all of their teeth start feeling sensitive? It's not just one tooth or two, it's all of them.
Yes. That is most likely to do with recession. So like I mentioned, the pink tissue has shrunk down and that has exposed the root surface. Which again could be due to like aggressive brushing, grinding, clenching, biting on pencils, and crowding of your teeth where the teeth are not meeting together, and hence because you can't brush, plaque has just shrunk the tooth. Or if you're a smoker, they can also damage your gums.
Thank you, Dr. Rai. So our final question for today is, you mentioned that when you look at radiographs, that if it's cloudy, it's an infection, but does the degree of whatever like is on the x-rays vary based on, does the degree of the x-rays vary based on like the radio like lucency or like how dark the image is?
So going back on the x-ray itself, the way I explain to my patient is what you see here is, if you think of a chocolate bar, the outer layer, I always call it the chocolate, and the inner layer, I call it the honeycomb. Okay, so what you can see here, these are the inner bone layer. Now within this, if you see something like that, at the end of the apex of a tooth, that is an infection. Like if you compare this, if we enlarge, can I enlarge this? Oops. It won't let me enlarge it. So that is not an infection, whereas this already stands out different. So that is an infection. What you see here, the white thing, these are all existing fillings in a patient's mouth. And these comes by experience. I have a foundation, a person that's recently qualified, a foundation dentist who just qualified. It takes time to understand an x-ray. It's not something that you'll pick up straight away. It took me, after qualifying, at least 2 years to actually read an x-ray properly.
And how about teeth number 24 and 25? Like the roots is kind of like cut off on the bottom. I'm not sure.
Yeah, sorry, you're doing your way. Yes, sorry.
I'm sorry, I don't know if the metric system is the same, but it's just the lower incisors.
Lower incisors, yes. So on an OPT, you cannot always see the anterior teeth. The reason why, if the X-ray machine is in front of us, it's just like that. What's behind us is the vertebra, you've got your cervical vertebra there. So that always superimposes. So it's not very clear. So an OPT, a DPT X-ray, you guys might call it DPT. It's good to see mostly the posterior teeth for any kind of supernumerary teeth, like here where the nerve is. It's not a good X-ray to use for the anterior, just because your spine is superimposed onto it. So I wouldn't think too much into the anterior teeth on an OPT DPT. Did that make sense?
Yes, absolutely. Thank you so much for clarifying.
So I have a follow-up question, sorry. So is it safe to assume when you're looking at an X-ray, if something is more radiodense in comparison to like radiolucent, that it is considered more healthy?
Not really. No, a super dense at this in the bone, it could be something cynical. It could be like a cancerous tissue, a tissue that shouldn't be there. So a super dense can also be taken as a negative. You may want to do some extra looking into it. It's just where that super dense is. If it's somewhere there, I would be worried about that.
Well, we'd like to thank you so much, Dr. Rai, for your session today. It was truly informative, and
you're welcome.
We absolutely loved how the layout was, how you went into details of screening the patient and treating the patient. We truly enjoyed the session, and we thank you again for your time and preparation.
It's been a pleasure. And like I said, if you do have any more questions, you can always ping it across through Instagram, or you can get my email, and I will endeavor to get back to you if you have any questions. I'm happy to help.
Thank you so much. And everyone that's watching, feel free to follow Dr. Rai on his Instagram page for more cases. And we will be posting the post-quiz shortly in our GroupMe chat. Thank you, everyone, for watching and joining us this morning.
Thank you.